slide, did I? Kia ora koutou. Welcome everyone to this month's professional webinar. And before I introduce Jai, this month's speaker, I just wanted to say I heard him speak recently at the symposium run by Postgrad School of Nursing University Otago in Christchurch, and I was very interested in what he had to say around methamphetamine and his research into that, and the issues around it. And I thought he had a really interesting perspective, and it's something that I think all health practitioners need to be aware of, and something that Jai has a vast knowledge about, which he's going to share with us today. Jai is Ngāi He's a recent graduate of Ōtākau Whakaihu Waka, where he now works as a postdoctoral research fellow in Ōtautahi. He's an illicit drug user and a harm reduction advocate who has conducted research across varied drug types. He has a range of interests in the field, including social and therapeutic drug use, Indigenous harm reduction, drug policy, public health, critical drug studies, and public education and perspectives on drugs. So I think this is a really critical and important topic, and I welcome you, Jai. Kia ora, and very happy to have you. Thank you for coming.
Kia ora, ngā mihi nui. Kia koe. Lorraine, thank you for the kind words. Can everyone see my slides up there?
Yes, right. We can see them. They have the
awesome.
wee slides down the side. Are you able to do full screen or?
Yes, that's a good point. I can try my best.
Perfect.
You got them? Cool.
Yep.
Thank you. I'll just get all this stuff out of my way. Working with one screen, which I'm not used to, so apologies. Awesome. Tēnā rā tātou. Nau mai ki tēnei kōrero. Thank you for coming along to my talk. As Lorraine said, I'm really interested in this area of methamphetamine. Broadly speaking, and I really love it. Love drug research more generally, and have been spending basically all my time thinking about it for a number of years now. So today's just going to be a little snapshot, some of the work that I'm planning on doing over the next kind of year and a half, which I hope is interesting for you, and there'll be kind of a lot of contextual stuff that I'll be talking about as I move through. But as you will have seen, all about methamphetamine stigma, treatment, and harm reduction options here in Aotearoa. Ko ai au, ko Jai tōku ingoa, he uriho no Ngaitarangi, hingari tipua ki au ki Waihopai. So I'm Jai, whakapapa to Ngaitarangi, and I've got a beautiful photo of my maunga mauao there on the left, but I grew up down in the deep south in Invercargill, so please excuse the R's if you're not used to them and the accent. One of the most beautiful accents, of course, in the world. And I think it's really important to me to highlight where I'm from, because there's quite a varied experience throughout the country, as I'll kind of get into a little bit more around drug use more generally and drug harm, and this can really shape our understandings depending on where we come from, and so it's just really important, I think, to make that really clear from the start. So a little bit more about the horapaki a te o ata whakaihi. A te o ata whakaihi being the Māori term for methamphetamine, the crystal that invigorates or enlivens the person. So this is a globally popular stimulant. Most of us probably aware that it's quite popular. We're hearing about it quite a lot. It's consumed via many different routes of administration. You could be someone that consumes this orally, you may snort it, you may smoke it, or even inject it. It is quite long lasting, particularly upon first use, and depending on the ROA can be upwards of 12 hours. And there's various motivations for use. Now, I think we're all quite aware of this, but whether we kind of are reminding ourselves of that variation very often is a different story. I think we often default to various understandings of why people consume various drugs, and of course there are different associations and relationships depending on a person's personal context, but we just need to be mindful that there are various reasons for using it. For some people it's to work harder, do more hours, stay up later, stay more alert perhaps when driving, and for others it's just to have fun. that's the same for methamphetamine as it is for other drugs. It's not just kind of the default that we often think about as coping and things like that. In terms of how many people are actually using it, well, the most recent stats say 1.3% have passed year use. That's the New Zealand Health Survey, although that may be, and it's likely to be an underrepresentation. Understandably, people are not necessarily reporting, on any survey that they consume methamphetamine. But I think more interestingly, more importantly, there are particular categories that have increased odds of past year consumption. So that's men, Māori, particularly Māori men, disabled adults as well. So anywhere from twice to almost 4 times the odds of consumption. I kind of alluded to it before, but it is an injected drug, and it's the most injected drug as far as we can tell. And in terms of the injection itself, we see more and more Māori injecting methamphetamine, which is something that we need to keep in touch with as best we can. Recently, one of my colleagues, Rose Crossan, conducted the New Zealand Drug Harm Ranking Study, and methamphetamine came in second as far as ranked by a bunch of experts in terms of how harmful it is, behind alcohol. I think it's really important to acknowledge the place of alcohol in our society as well, relative to some of these illicit drugs. And, notwithstanding that these are all, harmful things, methamphetamine has particular harms that shine through, if you will, within that study, including things like intergenerational harm, loss of tangibles that may not be associated with some of the other drugs that we're talking about. When we think about the social costs, the costs more generally of consumption, as defined by the National Drug Intelligence Bureau, so part of the police, we're coming in at around $1 million a kg. And as far as 2024 is concerned, that's totaling up to $1.5 billion in terms of total consumption. And just to put it into some perspective, I've got some other numbers here that give us a little bit more info. So some of these are from 2023. So alcohol in 2023 cost the country $9 billion alone, with methamphetamine being 865, so a little bit lower that year. Cannabis, 985 million. And within that number, 221 million is in foregone tax. So all the illicit drugs combined in 2023, we estimated to cost the country 1.94 billion. Quite a lot of money, definitely something to be concerned about, but still shadowed quite significantly by alcohol. So another important piece of context, I think, super relevant for us when we're working in this space and the way in which we deal with people who may run into issues with this drug. Also, really relevant and been in the news quite a bit recently, the amount of methamphetamine detected in the wastewater. So we regularly test a whole bunch of different sites across the country for presence of particular substances, methamphetamine, MDMA, and cocaine being kind of the predominant ones. And very recently, we've seen a major spike in methamphetamine use that hasn't appeared to have gone down as far as the start of this year. So we're kind of hovering around 18 kgs per week within the final quarter of the midway point of 24. And then we see a massive spike as of the end of the year, getting up to double that, and that hasn't gone down, which has been a major red flag for some people. But it doesn't. We can't say much more about what's going on there. We think it's because of increased availability, reduced costs of the substance, and just people being able to get more of it. But it's hard to know, whether that number is also including a whole bunch of new consumers that are getting into using it, whether the people that regularly use are just using more and account for that increase. We can't really tell that at the current time. Here's just a further breakdown of those numbers as in terms of the wastewater testing per district. So you can see actually in the southern, it's kind of the only region where the methamphetamine is kind of much less significant relative to the MDMA and cocaine combination. Bearing in mind, of course, southern includes Queenstown and Dunedin, two known youth or party kind of oriented areas, so we can kind of understand why that may be the case, particularly because those numbers are quite high relative to the amount of people in this location. But as I said also in my introduction, there's a massive disparity or difference in areas that are populated by significant percentages of Māori. So I'm thinking, Northland area, Waikato, and the eastern areas, and also the Bay of Plenty, where significant Māori communities there, particularly rural Māori communities, they are kind of bearing the brunt of a lot of this methamphetamine consumption and all the harm. You can see over the left side here, the national average. There's a whole bunch of sites above the national average as of the start of 2025. I try not to talk too much about these pie charts because they can be a little bit confusing and give us a false impression of what's going on, but the absolute numbers are still something to be really concerned about in terms of the harm that's associated with them. Just briefly, this is some research from the New Zealand Drug Trend Study. They surveyed about 10,000 people, and about 8% of those people reported past 6-month meth use, I believe. When we track that across time, we can see that the participants are saying that basically methamphetamine is getting cheaper per point and per gram, which is not something that's all too shocking, particularly as we are seizing more and more at the border. And so we also assume that more and more is getting through. With more product, the price can come down quite significantly. You can see since 2017-18 measurement, come down from 560 to 360, so quite a significant decrease. And from that very same study, we can see the distribution of people using or their frequency, whether they're using often or not. And with the most recent ones, 24, we see more people using daily or nearly daily or once or twice a week than we have historically. And of course, that means less people using only once or twice in the last 6 months. And really briefly, again, and potentially more important for this audience, we've got methamphetamine-related hospital discharges. So this is just some information that or some data they got from OIA. I asked for basically public hospital discharges with any code related to methamphetamine or primary codes kind of separated out. Now, we'll note that the 22.3 and 3.4 data is provisional, but just like the other stats, we can see increases going up here across the board since as far back as we've been using these coding systems, or as far back as the data that I could get. And it's probably going to go up again if I was to guess as of right now. And of course, as I mentioned, we've been hearing about this a lot. There's a lot of methamphetamine-related news and other drugs actually, and particularly in the last kind of 5 years, we've been seeing more and more information. Most of it not great. We've of course had this shocking story of the methamphetamine lollies, what people calling calling the situation a methamphetamine epidemic. We've got numbers being reported constantly. We're seeing it rurally. We're even having, the chair of Ngā Puhi Runanga calling for greater impact from the police, asking for raids. Historically, this is not something that has ever gone good for Māori, to ask for greater police involvement or any government involvement, really. And so it really highlights the desperation of the situation for some of our communities. And as I said, particularly in Northland, this is a massive issue for them. And a lot of the news is not really getting at any of the solutions necessarily. We've got a lot of, I guess, sensationalization of particular situations, but we're not having a lot of lengthy, deep discussions about what we should do about this. And quite frankly, I'm of the opinion that prohibition isn't working. I think most people probably could say with some certainty that they also feel the same. But what we do about that then is another question. And so this is where kind of my interest overlaps with this point. So I'm really interested in harm reduction, both as kind of practice, but also as a philosophy. And I really like this definition here from Harm Reduction International, which includes policies, programs, and practices that aim to minimize the negative health, social, and legal impacts associated with drug use, drug policy, and drug law. Now, I really like this definition because it goes wider than the drug use itself, something that we often kind of focus on because it's kind of all we can do, or it's all we think we can do when we're interacting with people who are coming into contact with drugs and may or may not be experiencing harm as a result of their use. But thinking a bit more wider than that, getting into that systems thinking is really critical within this space, particularly because of the way that drug policy has been used historically against various peoples within various nations across the globe. And, when we're thinking about drug harm reduction, I think a lot of people kind of fall back on perhaps education, or perhaps kind of long running programs that we have, such as the needle exchange. But there's a massive amount of things that we could be doing and are doing that will be categorized as harm reduction. Another really common recent example is the drug checking legislation that was world leading really for us, which allowed us to check the presence, absence, contents of somebody's substance without them coming into any legal strife for doing so, essentially. And this has been a really big win for us, but there's a lot more that we could be doing. And actually, the policy itself is really critical for this other mission that a lot of people are really interested in, which is decolonization and getting away from the colonial kind of situation that we find ourselves in still to this day, and have been influenced by historically, that has unfairly, inequitably impacted particularly Māori communities in this country. And for the most part, in almost every situation that I can think of at the very least, prohibition of drugs more generally, but in a lot of cases, specific drugs, has been used as a tool of oppression against particular peoples. And that's no different here. We've had a law outlawing opium that was specifically targeted at Chinese migrants. And kind of the list goes on throughout history and across the globe. There's been many different attempts or unsuccessful attempts really, to pull people down and keep them down. And this is still impacting the world in dramatic ways to this day. Over in South America, Middle America, we have international groups coming in to try and stop the production of, say, cocaine, and spraying those crops with poisons that then impact the farmers in the more general area. Not to mention they're being pressured by international crime groups to grow the crops in the first place. So we're causing a massive circle of issues, and a lot of the time we've got big players like America and Russia coming in and contributing to that harm. And although that is kind of painting it as this completely bad thing, it's quite a complex issue, and the way prohibition's been kind of used or levied against Māori and actually by Māori really highlights that as well, particularly in the case of alcohol. So we had Kiangi Tawhiao prohibit Māori in Te Rohi Pōtai in the King Country quite early on, and try to stick to that. Now, I'm not saying that was necessarily effective, but it's been kind of utilised as a tool by the Māori community when in another situation in which Māori are facing disproportionate harm. And so we find ourselves now within or under the MODA, the Misuse of Drugs Act 1975, turning 50 years old this year in October, and the Psychoactive Substances Act, which was our almost successful attempt at creating some sort of regulated market for particular substances, which eventually, or somewhere along the way got pipped at the post and didn't quite make it through. However, there's still scope to kind of think about how we develop these, and I think that should be part of our kind of societal next steps within drug policy, particularly as we haven't had a national drug policy change in a very long time. I'm thinking it's over 5 years overdue now, so a significant amount of work needs to be done to refresh this area more generally from a government standpoint, and it should definitely incorporate all of these things. And there's another really critical point here I wanted to raise is around stigma, particularly for methamphetamine. This is a big issue, and I think it's really important to reflect on what we mean by stigma and how this actually impacts whānau. And so, taking straight from the dictionary, it's a mark of disgrace, right? But I like to actually liken stigma to onga onga. So onga onga is one of our endemic nettles, and the great explorer Kupe, when he came to Aotearoa and was kind of running off with other people's wives, one of the barriers that he would use when he was being chased was onga onga. And I think that's a really good analogy for the way in which stigma can act in modern society, right? The onga onga or the stigma can act as a barrier, and it can actually be used as a weapon. We can pick it up, and we can whack somebody with that, and we can harm them essentially. And just like onga onga, I've been out there in the bush a lot recently. It's everywhere, right? The stigma is everywhere. It's quite pervasive. It pops up in places you wouldn't expect, and it's kind of an ever-present thing, it seems, at the moment. And so for Māori, that's a really big issue because Māori are then going to face double discrimination if they happen to use methamphetamine, because they're facing the straight up racism, which is ridiculous, and then they're also facing the methamphetamine stigma. And so there's a big issue here, and it's not an easy area to get into. It's not something that we can necessarily easily fix, but I think there are ways in which we can move forward with that too. And just building on that, drug stigma more generally has a waterfall of impacts for people that use drugs and their whānau. So we know that internalizing stigma can be harmful for the actual person. It can stop them from seeking help. They have worse mental health. People that are experiencing drug stigma are also reporting that here in Aotearoa, the stigma from health professionals is really common, and that's the same across the ditch as well. So some really key studies for me more recently have come from Alimaki in Western Sydney pharmacists being highly stigmatizing towards people who use methamphetamine, and then Stephen Potter more recently reporting on people who inject drugs in the stigma that they face, in particularly in emergency departments, but also with GPs and stuff like that too. You know, really disgusting. Essentially, we're talking about professions that are kind of have said that they're going to dedicate their lives to helping people, and then we have people coming in needing help and being degraded, humiliated, kind of not seen to the best of the capability of the professional because of how they see this behaviour. It's something that we really need to work on. Interestingly, stigmatizing attitudes are linked to lower knowledge about the substance itself, which maybe gives us some clues about how we can go about improving the situation. And there has been some work done in Aotearoa regarding stigma, not a huge amount, but a significant portion, and a lot of that has highlighted kind of a more general moral panic about methamphetamine. And I kind of am often in two minds about this because I acknowledge that this is a really big issue for people, and some people lose their lives because of their involvement or in association with their involvement with methamphetamine. But we're also talking about something that's much less significant than alcohol in terms of the total harm done. We're talking about something that's used by much less people than I think we would assume on the face of it. And often a lot of our opinions are driven by sensationalized media, or perhaps by people that have genuine concern who end up seeing the negative consequences of methamphetamine, which is often linked to all these other issues that we're unwilling to combat in the wider society, that being those things, like I already mentioned, racism, other stigmas, poverty, cultural disconnection. I think we all actually, when we step back, we know this, but when we find ourselves, in an emergency department or, at MSD or what have you, we fall back on the stereotypes, and we instantly feel negative, or feel afraid perhaps, or disgusted because of the context in which we're built around this kind of stuff. And so what do we do about all of that? And I've kind of thrown a whole bunch of information out, and it's quite a difficult picture, quite a lot to do, I think, in that space. And there's still some questions to be had, and I think that's essentially what led me to doing this work here. So I have a number of questions related to these concepts and the way in which these concepts fit together more generally. And I would like to privilege Māori voices within my work, because we are doing so little for Māori. We're underserving them, and they have the most to gain. And I think more generally, we've been shown that Māori ways of being and doing are really critical for Māori healing, particularly if we are currently still unwilling to make the major changes that we need to, that underlie all of these things, like the poverty. And so I'm really interested in finding out if there are particular things, thoughts, feelings, approaches that Māori think will be useful for reducing harm within the context of methamphetamine. And also related to that, as a kind of a really important po in the ground there, what is the impact, the experience of the flow-on effects of methamphetamine-related stigma more specifically, and are there particular ways in which we might be able to reduce that or cope with that that may or may not align with the current literature on stigma reduction? And then more broadly, what are the perspectives of the public out there regarding methamphetamine? What actually are they thinking? What do they know? What do they think they know, perhaps? These are some questions that I think if we had a little bit more information about, we'd be able to make some next steps and try to actually address and reduce the size or reduce these problems more generally. And so my research itself is actually broken down into two parts. I've got a qualitative portion and a quantitative portion. I don't want to talk about them too much, but I'm happy to take questions about them as well. The first big question for my qualitative component is, what's methamphetamine-related stigma look like, feel like, and how does that impact us? And so for this portion, I'm going to be sitting down with a bunch of Māori who have at least some experience of methamphetamine harm and have at some point consumed methamphetamine regularly, and just having a good kōrero about this, getting into the weeds on it. What do they think about this? And I'm also interested then, as a follow-up to that, on what we think, what they think, sorry, of the existing options around methamphetamine treatment and harm reduction, and also some novel ones. So I think a lot of us, we have our feelings about talk therapies and stuff like that, but I'm really interested in hearing what Māori have to say about more integrative approaches, using kaupapa Māori, using kapahaka, using arts, using the rongoa Māori. I want to know about safer smoking kits. Do you think those will be helpful? In addition to safe injection equipment, do you think prescribed Ritalin would be helpful for you? Do you need extra social supports? Do you need contingency management? All of these kinds of things are really interesting more generally, and I think getting the view of the people out there who are being impacted and who perhaps have not really had the chance to voice their opinion on these things, or perhaps even come across some of these concepts, I think would be really valuable. And then for the quantitative, as I said, I'm really interested in what people are thinking, feeling, and what's out there. So I'm really interested in the attitudes and perhaps the level of stigmatization that's out there more generally, and association with the knowledge about methamphetamine. So do people actually know what they're talking about when they think about meth, or are we all walking around with this false perception of what meth is and how it's used and all those kinds of things? And more generally within the quantitative stuff, I'm hoping I can get quite a large sample and we can start delving into some of these other kind of key areas that might be important for development within methamphetamine treatment and harm reduction. So what are the stigma stuff more generally, sources of stigma as well. Do we really need to hammer down on our health professionals, or is it kind of the public, if you will, without the experience, that have these kinds of negative views? What are the barriers to treatment as perceived by the people out there, and are there major disconnects there that we can address? And what supports out there for harm reduction again, and what well-being factors might be important for those things too, because I think we all have feelings about what's important, but if we hear it straight from the people with experience and compare that with our health professionals, again, we might find some disconnects that deserve our attention and kind of get some correction that can influence our practice in positive ways. So just moving forward, I do want to highlight all these key areas. I think they're kind of all stepping stones towards more work. By no means is this going to be, giving us major answers to how to fix these issues. But we are going to need to do something more. And without kind of these stepping stones on that way, we have no idea what we're going to be doing or why, essentially. And being able to support the workforce is another major part of this, and advocate for the change beyond that as well. So just in the interest of time, I'll stop there. Ngā mihi nui ki a koutou. Thanks for listening.
Yeah, kia ora, Joe. Jai, that's fantastic. Does anybody have any questions for Jai or any comments? I can't see any in the chat at the moment. Just while we're waiting, maybe I'm just very impressed by your work. I think if I'm getting this right, the kind of move from more punitive black and white stance through to actually saying the issues here, the issues increasing, the harm's increasing. Let's talk to the people who actually are involved with this and who have some knowledge, Māori who are higher users of methamphetamine. And also the stigma, I think of stigma in general. Yes, there is drug users, but there's a lot of attitudes and judgments and stigma that we sometimes are unaware of as health professionals, that we don't realize that we are actually being that way. So I think again, these are fantastic that you're uncovering these issues, and as you say, no easy answer. There is a question there, Jai. Someone's asking, what are your thoughts on decriminalisation versus legalisation?
Yes, great question. Kind of one of the age-old ones, if you will. I think there is no question that the thing we should kind of do immediately is decriminalise. We should at the very least be decriminalising all drugs. That, as I kind of alluded to, the prohibition, the legal aspect of this is not really reducing any use, and so it's only really contributing further harm to the people who end up getting caught. And we know, because of the way our system is designed, that we end up catching, because we are surveilling more particular types of people. In our case, that ends up being Māori or people with lower SES, or socioeconomic status. Sorry. And so I think that's a no-brainer. In terms of legalization, my personal view would be that this would be a good way to go about it, because again, the decriminalization is not kind of getting rid of the drugs. It's still going to, or at least the way that I'm envisioning it and the way that we generally talk about it, is this is for personal use and possession. So the supply of this is still going to be illegal. There's still going to be criminal networks and or others that are interested in continuing to make money. And so some of those issues will, with the harm that we cause to our justice system, will be solved to some extent, but there's still massive issues going on. And I think legalization is ultimately one way to solve this. Of course, the balance of the regulation and the things that we implement and the tools that we have surrounding all of that stuff and the support that we can provide people, including during that period of decriminalization, is really critical to showing, to having a society in which we are accepting the use and also being able to manage and prevent really any harm that may come from someone who decides to use that substance. And I think that's no easy task, but I think that's one way to go.
Yeah, there's a couple of other comments here. Commented question, Jai. One person says they love this. As health professionals, we need to be better informed with good balanced information. And I would agree with that. I think these are issues that we don't talk about a lot. And Steve Paddock from Health New Zealand, Steve says, thanks, Jai. Can you talk to the economics of production and supply? Is it a chemical process to cook? Who makes money from this?
Kia ora. Yeah, kia ora, Steve. That's not necessarily my area, and there's some really awesome academics here, particularly at Massey and the New Zealand Drug Trend Study, who are really interested in kind of the economic side of this, the supply and demand, the way the markets are working. However, yes, certainly to make methamphetamine, it is a chemical process. We had our own stint where we had massive amounts of local production, particularly from pseudoephedrine, sometimes imported pseudoephedrine, sometimes local, which led to the banning of that product in our cold and flu medicines. It's of course now back, but in that in between period, we had massive shifts globally in production and massive amounts of production in particular areas. So we had, we had the kind of the Golden Triangle. We had China, we have Mexico, we have all these different players across the globe, and they're all working with each other essentially. Well, they're competing with each other. They're working with people that are here, and then of course there's still some people that are making it here. But the sheer amount that is being sent over to our porous borders means that a huge amount of that's going to get through, and so the money for the cooks, it may be what it is, and I can't comment on that depending on the context. You may have some people making very little and some people making a lot, but the economics of it more generally is that this is big business. No different from any other drug trades historically, essentially. It's just that the numbers that we're talking about now are much higher than they were. Kia ora.
Okay. Well, thank you, Jai. If anybody wanted to get in touch to you to kōrero further, what is your email address? Would that be the best way?
Yeah, they can flick me an email at, so I'll put my email in the chat actually. It's jaiwhelan@otago.ac.nz, so just first and last name with a dot in between, at Otago. That's probably the best way to contact me. And yeah, always happy to chat about this topic, whether that be, informally over the phone or over a Zoom, or if you'd like this kind of more information presented in another way, then ka pai. I'm always around and always keen to talk about it. Probably a bit too much.
You're passionate. Well, thank you so much, Jai. Kia ora, and all the best with your future studies. There's another question actually. Just have we look. Someone says, thank you for the great work. Will it be published, your work, eventually? I mean, in somewhere we might see it as health professionals.
So, I mean, all part of this, hoping to get whatever comes out of this out there in the world. I'm hoping to do that in a number of ways. So there'll be your kind of traditional academic publishing, but that's often stuff that doesn't make it out there to the community that deserves to see it and should see it most of the time first, actually. So I'll be doing a lot more speaking. I'll be going out visiting people as much as I can, and yeah, when this is coming close to wrap up, I'll be happy to come back and share what I've found. Might need to do a couple of these though.
Fantastic. Thank you, Jai. Kia ora, and all the best with your study.
I'll be here.
Kia kite.
Kia ora koutou.